Hi, everybody. It's Jean Sachs. I'm the CEO of Living Beyond Breast Cancer. And today we will be talking about the 2020 San Antonio Breast Cancer Symposium. This is really the big meeting for anybody and everyone who is interested in scientific advancements in breast cancer. Of course, this year, it was done virtually, but really important that it still happened, but sad for all the advocates that weren't able to be together and connect. So really hoping next year things will be different. But today we're very fortunate to have with us Dr. Virginia Kaklamani. She is one of the co-directors of the symposium and a professor of medicine in the Division of Hematology, Oncology at the University of Texas Health Science Center, and she is the leader of the breast cancer program at the Cancer Therapy and Research Center. So welcome, and thank you so much for joining us.
Thank you for having me, Jean.
We really appreciate it. I know you had a long week, and from what I know, you're probably still reading through lots of studies. So we won't take too much of your time, but if we could just jump right in and just get your take on what was the big news coming out of this meeting? What were the important studies that our community needs to know about?
So I think one of the most important studies that were presented was the RxPonder trial. This is a trial looking at women with early stage estrogen receptor positive breast cancer who had 1 to 3 positive lymph nodes. And that trial tried to see whether there's a subset of these women that we can safely avoid chemotherapy with. And the answer is yes, we can. So they ran a test called Oncotype DX, which is a genomic test. And they found that women who are postmenopausal, whose Oncotype DX score is anywhere between 0 to 25, do not get a benefit from the addition of chemotherapy. Interestingly, in our premenopausal women, there actually was a benefit to chemotherapy. So that's very important because that was probably surprising to most of us. The goal of the study was to show that chemotherapy doesn't benefit either the pre or the postmenopausal women. But I think one of the thoughts is that chemotherapy in this younger patient population puts them into menopause, and putting them into menopause decreases the amount of estrogen that they have. And this by itself decreases the risk of recurrence. So whether it's a chemotherapy effect, whether it's a menopause effect, nobody knows. We can't tell from this study, but the end result for somebody going to clinic on Monday morning is that these women that are premenopausal will benefit from chemotherapy, but the postmenopausal women will not.
So that is so interesting the way you just explained that. So because I was going to ask you specifically about the premenopausal women who, of course, will have to continue having chemotherapy. So you think part of it might be just the impact of the chemotherapy and shutting down their ovaries?
Well, the Europeans have been thinking that for a very long time, and we've tried to do studies. We actually did some studies in the late 90s in the United States, and the studies, the way they were designed, did not have the perfect arms. And a big part of it was, the goal of any study is to try to recruit patients. So you have to have the physicians comfortable with the study, you have to have the patients comfortable with the study. And it was very hard to randomize women to chemotherapy versus no chemotherapy at that time. And so the perfect study was never done. I don't even know if it's going to be done. But the end result is that, some of us feel that it's a chemotherapy effect. Some of us feel that it's a menopause effect. Until we know for sure, I think most of us will be compelled to give women chemotherapy. Mm-hmm. But I bet you it's us shutting down the ovaries with the chemotherapy that's really doing it.
Okay, well that's very interesting, and we'll keep following that. So what about the CDK4/6 inhibitors? I know there was 2 different studies on that new drug.
Yeah, so the CDK4/6 inhibitors, as you know, have revolutionized our treatment in metastatic estrogen positive breast cancer. They've improved survival by quite a bit. They're drugs that we now use as standard of care. And these are the first studies that have looked at early stage breast cancer to try to avoid metastatic disease altogether. And one of the studies called the Monarch E trial was positive, showed that abemaciclib, which is one of the CDK4/6 inhibitors, improved outcomes. Another study which was the Penelope B study, which was a much smaller trial, did not show a benefit. these drugs seem to be beneficial for very high risk women. So I don't want people coming out and saying, oh my God, I have a one centimeter tumor, negative lymph nodes, I should be on a CDK4/6 inhibitor, because the answer is no. But for women who have multiple positive lymph nodes, larger tumors, these drugs may be effective. It's still a little early to tell. If you look at the length that these studies went on for, that we have results so far, we're talking about a couple of years. And as you know, ER-positive disease can recur 5, 10, 15 years later. So having data for a couple of years is probably not enough, but it definitely is an early sign. We'll see what the FDA thinks of the data when they look at it to see whether these drugs will be approved in the early stage setting. But definitely something that I think has a role in treatment of ER-positive early stage breast cancer.
Right. Well, it's exciting to see this new type of treatment moving into the early stage setting. It's been in the metastatic for a while. I know there was some new information about pregnancy after breast cancer. You want to share a little bit about that?
Yeah, and that was a meta-analysis. We've had now a lot of studies. Obviously, it's very hard to do the perfect study. Take half of the women and tell them to get pregnant, and the other half and tell them not to get pregnant. So all the data that we have is from analyses on women that have had breast cancer and have tried to get pregnant, and some of them have and some of them have not. So there's a lot of biases going in, but the bottom line is it seems to be safe for women to get pregnant after breast cancer, but it's definitely not easy. The drugs that we use as far as chemotherapies can damage the ovaries and cause a lot of fertility issues, which is why it's so important for women to try to have some sort of fertility consultation before they start chemotherapy. And the notion of, oh my God, am I going to delay my treatment? That's okay. The treatment will be delayed by maybe a couple of weeks. But the whole point of trying to have some fertility preservation is extremely important for those patients.
Right. So here we go again. It's good to have chemotherapy because it damages your ovaries, but then it makes it harder for you to get pregnant. So yes, so important to have that consult with a good reproductive endocrinologist. And Living Beyond Breast Cancer has a lot of resources on that. So for anyone who needs it, please come to our website. So moving to a different area, there was a study that found symptoms were under-recognized during radiation treatment, and that doctors were reporting conflicting accounts about people making their appointments, especially with younger and people of color. So if you could share what that was about.
And that was worrisome. In up to 30% of cases, there was a difference between what the patients reported as symptoms and what the physicians reported as symptoms. So it seems like we're not paying as much attention to our patients as we should. Radiation causes side effects, and if we're not recognizing those side effects, that's a major issue. It's also important to counsel our patients ahead of time as to what to expect, so that women go into it knowing that, yes, they will have some pain. Yes, they will have some discoloration of their skin and some burning and some swelling. And this is just part of the radiation course, so that once the expectations are understood, that it's easier for them to go through the treatment. It's easier for them to understand what their side effects are, understand that this is not foreign. They're not the only ones experiencing these side effects. Mm-hmm. And again, the communication between the physician and the patient needs to be better.
Yeah, it's so interesting. I mean, we certainly hear from a lot of women how fatiguing radiation can be, just having to go 5 days a week, usually following chemotherapy or surgery. And I think that, they're sort of told just push through it. But I thought this was really interesting. We need to make sure patients really share what they're experiencing with doctors. So can we move into the metastatic setting and just share what were your big takeaways for the metastatic community?
A couple of very new exciting drugs would be my takeaways. One is an oral taxane called Sachs, and that was from a clinical trial called the Contessa trial. And as you can see in oncology, we're moving more and more toward oral medications. And this has some good things and some bad things to it. But the Sachs seem to improve outcomes when you combine it with capecitabine, which is another oral drug that we have. this is the first study. I think, this is a registrational trial. The FDA will look at the data. I think it's very likely that they will approve the medication, but this is just the first step to using taclitaxel in the metastatic setting and then in the early stage setting as well. Fewer toxicities, less neuropathy, very little alopecia, which is extremely important. Women won't lose their hair. Actually, a small number of women lost their hair. So again, very promising for metastatic. And this was ER positive, but there's trials ongoing for ER negative as well, breast cancers, and I'm sure HER2 positive will be coming soon as well.
Great. Anything else for the triple negative?
So for the triple negatives, the ASCENT trial looked at an antibody drug conjugate called sacituzumab govitecan. I can't pronounce that name. I can't either. Don't worry. It's also called Trodelvy. And it showed a doubling of overall survival. So these triple negative breast cancer patients that had already been on at least 2 other treatments for metastatic disease, when they were on Trodelvy, they lived for 12 months versus 6 months if they had received our standard of care chemotherapy, which was actually a very good chemotherapy. So this drug is already approved, but it was conditionally approved based on the results of this trial. The FDA will look at this data as well, and I'm sure they will continue the approval of the drug. And because it's an antibody drug conjugate, it's a little more targeted, not as many side effects, which again is so important for our patients.
Yeah, and I think this move to more of the oral chemotherapy, particularly while we're dealing with COVID, I think has been a good thing as long as there's compliance, but that less trips to the hospital.
And you pointed out one of the issues with oral chemotherapy, compliance. When you get IV drugs, the patient and the physicians know that they get it because they come to clinic, they get the infusion, and then they go home. With the oral medications, are they getting it correctly? Are they taking it with or without food? Are they throwing it up because it causes nausea? Did they even pick it up? Did the specialty pharmacy send it to them? When did they start taking it? How much is the copay? All of these things are extremely important with the oral medications that don't really exist as much with the IV medications. And our patients need to be very aware of that, need to go on the company websites and get the patient assistance information. All of these companies have really good patient assistance information that the patients need to go and check out.
Yeah, I agree. It's complicated, and but definitely a direction that is hopeful to be moving in. Well, I want to end asking you about immunotherapy. I know the breast cancer community has been waiting to see if, immunotherapy is going to be effective. So what did we learn?
Immunotherapy is effective, but it's effective in a certain certain kind of breast cancer patients. So in the metastatic setting, we have now 2 or 3 different clinical trials with large clinical trials with in triple negative breast cancer. And it seems that a subset of triple negative breast cancer that has what we call immunogenic tumors, so tumors that immunotherapy can target, those tumors get a benefit from immunotherapy in combination with chemotherapy. But it also seems that immunotherapy is beneficial in the early stage setting in patients with, again, triple negative breast cancers that have pretty large tumors, where you give it in combination with chemotherapy, especially prior to surgery, they can improve our outcomes. So I think very important for our patients to know that these studies are already finished. We have 2 drugs approved in breast cancer now, the second one approved about 2 or 3 weeks ago. And there's a lot more to come.
Yeah, so that is exciting. And all of these studies, if you go on to lbbc.org, you can read a little bit more about them. So anything I missed, anything else you want to add?
I think the one thing that we have not discussed, which is so important for our patients, is the use of opioids. There was a study looking at women having mastectomies and potentially reconstruction, and how many of these women were converted into chronic opioid users because of these surgeries. And it showed that 13% of these women were becoming new chronic opioid users. And this is very important, and this is a failure of our system in many ways. These women are having surgeries. Some of those surgeries are not completely medically necessary. And maybe they're not being told ahead of time what the risks are. Or maybe they have some preconceived idea that this is exactly what they need to do, and they go and have these surgeries done. And then the other failure of our system is we're not able to help these women get over the symptoms by offering them non-pharmacologic treatments. And so the easy thing is, oh, here's a prescription for Norco, here's a prescription for morphine. And then when the woman comes back and says, oh, I'm still having pain, well, here's your refill, and here's another refill. And next thing you know, the woman's addicted. And these are, and most of the women that this happened to were younger women again, women that had Medicaid, women that were also getting chemotherapy, women that had breast cancer, because that study included women that were having these procedures for a variety of reasons, not just breast cancer. So our patients are high risk for becoming addicts, and we are the ones responsible for that. And our system really needs to be geared toward this and make sure that we counsel our patients, and we also offer them other strategies to help with their pain.
Wow, I did hear some conversation about that, and it was really shocking. And I think as an advocacy group, we will think about what we can do. We really do try to help women make the best informed decision, and sometimes more isn't that better. But I think it is often hard for people to understand, like, wouldn't I want to do the most to prevent? And that surgery is a big deal. It's not, it's not a little thing. And
not, especially those surgeries are big surgeries. Reconstruction could be a 5 or 6 hour operation.
Yeah. So, and there's risk for infection and long-term complications. So we will certainly do what we can. And if you have any ideas to share, but that's just so distressing, because we already know the opioid problem in this country alone is completely out of control.
Mm-hmm. It is.
Well, thank you for bringing that to our attention. Well, I want to thank you so much, Dr. Kaklamani, for your time and for all you do all year long for the breast cancer community and for the symposium, which for all the advocates is really such an amazing opportunity. I've been going to those meetings for so many years. I remember when they were very small, and now you go and there's just so many advocates that are integrated in along with the international scientific community. So do you think we'll be able to be together next year? Can I ask you?
I think so. We're starting our vaccination this week, so I just had to sign up for it, which is exciting. I think it'll be a combination, honestly, of a live and a virtual meeting, because some people may not be able to come. And it's, as you mentioned, so important for this data to be shared all over the world.
Yeah, and all of you and all of your colleagues are so generous with their time and their sharing their information with the advocate community. We really can't thank you enough.
No, thank you.
So thank you for spending time with us. Remember, everybody, go to lbbc.org. We have more information on all these studies, and we will be continuing to follow the trials and provide regular updates. If you're in need of support, remember, we have a helpline as well as closed Facebook communities. So all you have to do is log on, send an email, and we will join you to those communities so you can connect directly with other women who are in a similar situation. So take care, be well, and stay safe.